All right, back again. So, it morphed a little bit from embryology, and I'm going to actually skip through the embryology section now, just to cut down on some of the slides. I'm going to start with clinical implications, just to try and give it the nuts and bolts for those of us who want to make sense of some of the congenital deformities, and immediately takes us to one of those mantras that's just going to be useful for all of you to remember when you're faced with that impossible to answer question about an embryological defect. Fall back on the Swanson's classification. Remember, it's going to be formation, differentiation, and segmentation. So to form into a recognizable unit, or to divide. And segmentation is often integrally related to a process of programmed cell death, apoptosis, duplication, in other words, making multiple parts, overgrowth and undergrowth. And we can talk a little bit about them in other talks, but not this evening. Constriction bands is the one that you guys always forget. And then just right at the end of it, the generalized anomalies and syndromes. And then just to point out at this stage, because it has some reference to the talk, that a transverse arrest just means that a limb segment, either completely or partially in a transverse manner, has arrested. That makes sense. Whereas a longitudinal arrest is going to have more relevance to ourselves this evening. Longitudinal arrests refer to either post-axial usually, or pre-axial, which is either going to be pre-axial is going to be radius and tibia, post-axial going to be ulna and fibula, and it means that segment is either completely or partially arrested. And having said that, remember that there's a German word, an Anlage. An Anlage means a precursor, a foundation for what is to come. And so even though there might be what appears to be a complete longitudinal arrest, often that Anlage remains, which goes a long way to explaining why, if there is a pure, for example, radial aplasia or a radial club hand, that in addition to the lack of a radius, there's also a radially deviated ulnar bow because of the tethering effect of that Anlage. Okay, so these are Greek terms. They're largely historical. We're trying to get away from it. We're trying to get to a point where we just talk about the segment that is missing and what is left behind. But you are going to come across some of these. Amelia is a complete absence. The focomelia was important in the days of thalidomide, very classic of thalidomide, that a certain segment of an upper or lower limb would be missing, but leaving behind usually the distal segments. And so focomelia, by definition, really means a flipper limb. It looks like a seal. Adactyly, ectrodactyly is the now intermediate, not the new, because the new is going to refer to what segments are missing, but ectrodactyly is the more politically correct term for a lobster claw hand. It's those forefoot, those deformities where the middle digit is lost and there's clawing around it. Failure formation. Now, I'm not going to skip through these fairly quickly. I've just left the slides behind to remind us of the overview of the process. Failure of differentiation at times is going to be when a certain part has differentiated improperly, and a segment of arthrogryposis falls into this. The other segment of arthrogryposis, so the segment that relates to a failure of the joint to differentiate, yes, but the other segment of arthrogryposis relates to the fact that there's probably a failure of innervation of the muscle supplying the joints, and for that reason there's a secondary. So it's either a primary joint defect or a secondary to a neuromuscular lack. And for the rest of us, we're going to glance through these. A springal shoulder on the left, probably a clipper file, a syndactyly on the right. Duplications are just that, and the variants of duplications, either duplication of the hand as it stands, or very rarely, and Steve Carter's just had one, a mirror duplication, which is very, very rare, happens as a result of both a lack of a segment forming, either radius or ulnar, and then on top of that, a duplication of what's left behind. In order to get a mirror, you need to have the relevant components of what there is. Overgrowth and undergrowth, constriction bands you're familiar with, just had one at Red Cross, turning out fairly well. And then syndromic, and in the corner there, it's going to be a radial club hand. Remember that that's primarily related to vectoral, but also Holt's Aram. We can go through the differential at another point. Okay. So there's vectoral, there's generalized anomalies. And now we get on to actually what we had to talk about, which is going to be the leg deficiencies. Bear in mind that the lower limb is divided into a thigh and a leg. Yes. So it's a little bit pedantic, but language can need to be precise. And so to refer to the lower leg is to basically is tautology, is saying the same thing twice. Fine. What is it when you're faced with a case for yourself, for the parents, for the examiner, which should be the last on your list of criteria, but nonetheless, what do you really need to know, and why would you need to know those things? So in all of the cases we're going to need to know is to start with the diagnosis, and hopefully I'm going to take you through, let's call it a cheats guide, to try and to get to, you're quite welcome to the, Jacques, you're quite welcome to the whole talk in its entirety, or you can take specific slides. I'm just trying to save you the time, listen to the talk. I had this discussion a couple of days ago with one of the other consultants, which was to say, why don't we just take out a relevant review article of a topic and give it to all of the registrars and be done with it? And I think part of it is that while I'm not going to give you everything that there is to know, what I can do is to give you certain pointers as to easier pathways to diagnosis, why it would be associated, and triggers for associated pathology prognosis, which would guide management, if that kind of makes sense. Along the way, with a diagnosis, we should have just a feel for incidence, and we'll talk about how to get a grasp of incidence when that comes up. We don't know about transmission of diseases. In this case, they're going to be largely genetic, because that points to the risk of recurrence for other children. At the same time, we're going to talk about in a congenital problem, anomaly, how is that tissue that we're dealing with, that tissue that's been, let's call it, left behind or improperly formed, how is it going to respond to things like lengthenings? And if it behaves differently, how is that going to alter risk of progression? We also want to know about associated pathology. We've mentioned radial club hand and associated syndromes. And importantly, and we often make this point, if you just left the whole thing alone, what's going to happen? Fine. So in terms of classification, I don't want to bore you with this, but we want to know about prognosis, treatment. Classifications might also teach us or be valuable in terms of research. And at times I shy away a little bit from classifications where they don't help us with the first two, prognosis and treatment, because I find that they become clumsy, they become over-detailed, very difficult to remember, and really not of much practical benefit. Having said that, some of the widely accepted classifications that we're going to have in the leg are in themselves not very valuable in terms of treatment and, in fact, or prognosis. So in terms of treatments, I've got a tiered system in my head. that becomes useful. So if you get asked the question out of the blue, how do you treat pathology X? And I think a good point to start without rushing in to the difference between fixed angle versus compression docking plates, doctor, is to start with the goals. And the goals in a fracture would be, the goal would be to get union, or to have limb alignment, or to stay away from sepsis. The principles are very much related to the goals. So the principles would be meticulous open reduction, or would be absolute or relative internal fixation, or to be avoiding, in this particular instance, operating altogether. And thereafter would be strategies. And here we can delve into whether you want to use fine wires or external pins, or you're a frame person versus an ORIC person, or your particular type of total hip replacement. But try and steer that approach in those kind of categories. It avoids the potential with your examiner of starting to argue about external fixators versus open reductions. But it also helps in my own mind to clarify what is it we want out of a treatment. Fine. We also need to know what are the controversies going to be. So I, for example, might be that person who wants to follow a particular line of thought in terms of treatment. So I'm not a frame person. I've decided that I want to use plates. I need to, at the same time, be aware that maybe always using plates is going to be relatively controversial in certain areas, and be able to address it. Doesn't mean that I have to use somebody else's method. Just means that in a balanced perspective, I need to have an understanding of the literature. And then in terms of treatment, what's a reasonable chance of success? Or what's going to be the risk that we take in order to get there? What's the complications? What's the rate? And even if a complication is infrequent, what's its relative impact? So it's not good to me to say that the risk of death is only 2%, because if you're one of those two, you're dead. Better to say that the complications that do exist are relatively extreme or simple. We all accept that every patient, almost every patient, is going to get an external fixator, is going to end up with contracted sepsis. It's a complication, but has a far lesser weight than other things. Okay. And are there outcomes? Fine. So I'm going to now push on a little bit and get to this. And I'm going to ask, just because you do have the Galaxy Tab A7, person Galaxy Tab A7, just give us an approach to this clinical case. And I'm giving this massive clue that the tutorial this evening is on leg deformities, congenital leg deformities. So we've steered right into that territory. And I'll actually just tell you up front that this is not a congenital pseudoarthrosis, because that's going to come right at the end of my touch, and it's not a posteromedial bow. So you've only got two things left. It's either going to be a tibular aplasia, or it's going to be a fibular hemimelia. What are you going to choose? Because this is one of the things that your review article is not going to tell you. You're going to be faced with this photograph in your exam, and you're going to be faced with this patient in your clinic. So, the Galaxy Tab has disappeared. That's awesome. All right. Okay, Francis, where are you going to go? Okay. So what is displaced medially? What's displaced medially? I agree, Francis. Thank you.
Soft tissue, thickening of the skin of my callus on the side.
Okay, so on the lateral malleolus, you agree, yeah? Mm. Hmm. Okay, so I agree with you completely. So the vacuum that exists is in the tibia. Your foot is falling into that vacuum. Is most likely a tibial aplasia. What else is going to give you it away? Because I've underlined the thing right at the end there. What's happening with the knee profile?
If you sort of look at the anterior line from the knee down the tibia, there's a little posterior sag. So an impression.
Okay, what now? Put you on the spot. Not in this case. So yes, you may well have a PCL deficiency, but that's not going to be the issue. That's not primarily the issue here at the moment. Why is that knee sagging backwards at this young and tender age? And it is ligamentous. What? Yeah, no. I mean, I do think that there may well be. Yeah, okay. So, all right. So then I'll go with exactly what you're saying. Why is the ACL deficient? I think it in different terms. Why is the ACL deficient? There's nothing to say. Okay, so we're getting to where I want to go. Okay, exactly. So there's both a quads, let's call it deficiency, and an ACL deficiency. The tibia's or where the tibia should be is sagging backwards, and so we can probably reasonably state that the proximal tibia is not present. So there's actually two bits of information, but we've got at least a partial tibial aplasia, yes, because your foot has fallen away from it. It has fallen into the hole that has been created by the tibia, and these elements of the proximal tibia are no longer there. Yeah, got it. Happy? So yes, it is a tibial aplasia. Anybody? Dane, I've got a classification. You cannot come up with any classification. I am anything. Top of your head?
Yeah, it's having read this before the test.
Yes.
It's Jones.
Well done.
And it's got to do with where or which part of the tibia there is. So the tibia can be absent.
Mm-hmm.
The tibia can be only proximally. The tibia can be only distally. And then there's a fourth kind that I can't remember now. But
yeah. That sort of association distally with the rotational deformity tibia and fibula with disruption of the normal profile of the ankle joint. I get it. So quite right. And listen, there are other classifications. It's one of the examples of where I find an existing classification to not help me. Because if we follow the logic here, we're sort of saying that number 1A is the worst possible, and it is. There's no tibia. And we're saying number 4 is the best possible out of a bad group, because there's a whole tibia, but there's disrupted ankle joints. Maybe we can reconstruct it. We've got some experience of that. But then type number 3, I would have put next to type number 1A, because now there is a tibia present, but it's not useful to us in any way. You know what I mean? We like hop, skipping, and jumping. You can see what I mean? Because for me, the type 2 should be sitting next door to the type 4, but you follow it. And so in my own simplistic way, what I really want to know out of a tibial aplasia in terms of the focal pathology, what we're looking at in the leg, is going to be, is there an intact knee with an intact extensor mechanism or not? And my reasoning is this, is that if we don't have an intact knee with an intact extensor mechanism, then that knee as a unit is functionally not going to work. And I know somebody here is going to remind me that there is a procedure to now bring the fibula down, stick it into the notch of the tibia, and I've seen such examples. One of them two of them have come my way from other people. The problem is that pseudo joint is completely unstable, and it becomes an enormous prosthetic problem, because now you've really got a bone flapping around on the end of another bone. The options at that point would be to make a long lever arm, and I'd accept that would be a viable thing. It would get you cosmetic length, but not functional length. And to try and expect a fibula, and remember that although the fibula is not insulted by this process, there's nonetheless a deficiency in this leg. To try and get that arthrodesis and an artificially created knee is also in itself a problem. So I'm trying to say that to me, and I think that I'm here with 95% of most pediatric orthopedic surgeons, the lack of an intact extensor mechanism and a knee is heading through to a through-knee amputation. It's a good procedure. And I've got a completely separate talk on amputations, but just pause for a minute and realize the cost to institution and the cost to the patient, including psychological cost, of repeated futile attempts at reconstructing something that eventually doesn't work. I hate to bring it up this early in the evening, but he did cross my radar. Our Paralympic athlete who was now refused bail. But one of his pleas in mitigation of his crime was that he had suffered psychological damage by being operated on at an early age for his own particular pathology. The fact of the matter is that we, Cape Town, Teddy and myself, were asked to comment at the time, and the literature is very clear, is that there's far less psychological damage with a single timed and successful amputation, of which he had a variant. He didn't have prolonged stay with multiple procedures. That's the fact of it. The whole thing disappeared quite quickly. So once again, in the balance, and we went back earlier, what are going into the complications? The complication of repetitive surgery is in itself going to be harmful. Okay, if you've got an intact extensor mechanism, and now we're talking about the type 2, and or the type 1B, and it might be in the process of forming, and you've got a proximal tibia, you've got a viable knee joint, there's something to work with. Now we're looking at something a little bit different. You're going to have now a leg below the knee that is functional, that is going to have the capacity for flexion extension, is going to be stable, and which is going to be a lever arm that is suitable for something like a Symes amputation, a very successful Symes amputation, and we've seen how successful it can be. The type 4 I'm still unclear about. I think that there might be type 4s and 4s. We have had experience in the type 4s who do have an extensor mechanism and a knee of trying to reconstruct an ankle, but it's a difficult procedure. There's not just the absence of length, there's also rotational deformity, and for that reason I would be cautious about it unless there are quite clear indications. And I think one of those is going to be a very normal looking foot. I think to be tackling a club foot in addition to a type 4 is often too much to take on, and certainly our experience of a lot of those children has been a revision to a Symes amputation. Any questions there so far? Okay, so this is my criticism of the Jones classification, but just that is the classification. It's a guide. Bear in mind though that the crux of it surrounds the knee function. I've sort of said this: non-functional knees, through knee amputation, maybe reconstruction. Still not sure about that. Whereas when you have intact quads and a functional knee, go for a Symes. If you in addition have a functional foot ankle reconstruction, once again you're welcome to the slide. So here is the same set of questions, and I'm going to go backwards. Kim, and so remember these: position of the foot, dimple, bow, and knee profile. It's less clear here, but I'm telling you again, once again, Kim, this is going to be, first of all, where is the dimple? Anteromedial lateral. Yep. Okay.
And the foot is technically flat.
Okay.
It's also a missing toe.
Correct. Well done. Mm-hmm.
So I can't see the whole foot, but I would be concerned about foot pathology as well. But
yeah,
just from this clinical picture, with the foot going laterally, the dimple, the opposite one, so this would be the
fibula hemimelia. Okay, so that's great. I'm happy about that. And so yes, I agree with all of that. Just stressing again, it's quite right. The foot falls into the vacuum, that fibula, that the bow in the tibia is now created by the call it the tension band of the onlag. Francis, am I right there? My German translation. It's a German word. Am I right? It's a German word. A German word without an English translation. It's like typical. The only atypical thing about that German word is it doesn't have 14 syllables. Is that right? Yeah, fine. Kim, just get back here. Your associated features with fibula hemimelia. Yes. Correct, well done. Anterior, posterior. Okay, good. It's the one I always forget, but yeah. I mean, I forget until I have to deal with one. Absent lateral raise. So it's a post-axial deformity. Just quickly remind us again about the rotation of your upper limb versus lower limb in terms of embryology and development.
So your pre-axial is going to, or your pre-axial will be on the side of your thumb on your upper limb, and the big toe on
and it rotates, your upper limb rotates which way? Yeah, it comes. So in your anatomical person, then your anatomical them, is that right? Comes down, thumb palm facing forward, thumb out. Yes.
Yeah, so it's your big toe.
Correct. Okay. So just to bear in mind that those are all kind of related. The post-axial deformity in the leg is going to be fibula hemimelia. There is the association with the PF50, and with that comes a ACL deficiency. Your missing rays, tarsal coalitions, congenital short femur they throw in there, but that's another talk. Let it alone. Okay, so we got all of those. Thank you very much. Classification, now it's getting even simpler. Maybe it's a good thing. So Achterman and Kalamchi. I think in the lower limbs, you've got a fairly good chance, if you pull out the name Kalamchi at some point, of striking gold. So here is, and I promise I'll give you these slides, but you're going to have the partial and complete. Yeah. What's important to me with now remember, now you should have a knee. That's no longer an issue. And you, in my head, having a knee, you've also got a tubular bone beneath it. So you've got at least a Symes amputation available. What to me is now important is have you got a stable ankle mortise with a normal foot? Or, which is usually the case, have you got an unstable mortise with an abnormal foot? And we'll just talk about a little bit about that now. But I think give it to me that the middle clinical X-ray, not the clinical picture, the X-ray shows that your foot is deviating out to the side. That tibia itself is short, but it hasn't yet bowed in the picture that we can see. But you can see potentially how that entire ankle mortise is unstable. And I think it's important, just think to yourself a little bit about your 65-year-old diabetic with that neuropathic foot and ankle, how very difficult it is to, when there's lack of proprioception, to keep control over an ankle. And in a similar way here, when there's lack of mechanical stability. So I blanked out some of the stuff. What are our treatment goals in this case? And I think you need to be restoring axial alignment. And although it's not axial alignment at the same time as restoring, let's say, normal anatomy, possibly restoring shortening. It's not necessarily going to be the case if all you're dealing with at this point is the potential of a Symes, because sometimes you, for good reasons, you don't want a Symes to be the same length as the other side. There are issues with prosthetists. And I'm gonna pause us now and just ask, what's a Symes? Somebody run through a Symes. It's a bit early for November. Run. Never too early for November. What? Just run through us the Symes. Top of your head. Okay. So, all right. So, muttering a bit, but yes, it's a through ankle amputation. Got it. Retaining, not. Does it retain calcaneus? Does it retain talus? Just so the Symes by itself just retains the heel pad. The heel pad is critical. What retains the calcaneus? So yes, but it's going to be a Boyd. Boyd, yeah, Kim, nobody wants a smart ass. Yes, a Boyd, you're quite right. And when you flip the calcaneus, we talk about a Boyd Purgoff. When it rotates a little bit, I don't like the let's call it your tender Achilles retaining amputations unless you're very careful, because now you've got an extremely powerful plantar flexor of a potentially rotatable segment, and my experience has been that often you end up with a very difficult to control plantar flexion, and in particular one which exposes a non-weight bearing surface. You retract the heel pad and leave behind a very fragile piece of skin. But be that as may, I think that a Symes is good amputation. I think that if you can contain or control the plantar flexion, either cutting a tender Achilles or tendon transfers, I'm not sure that any of them are strong enough. Whatever you do, I think there's huge benefit to retaining an end-bearing stump, which is the essence of a Symes. And I don't want to get into the case again, but it did allow the defendant to get up out of bed without putting on prostheses and run with a loaded gun to the bathroom. Yes, fine. So it's a very functional amputation. Hey? No, it was accepted in court. It's an open matter. So let's agree that you want axial alignment and length. Then you need to be deciding, have you got a mortise stability? But with an abnormal foot. If you have that mortise, that ankle joint, you can then decide to address the foot or bail and amputate the foot itself, but ending up with a Symes. The downside is going to be to address the foot with potentially multiple deformities, and what are you going to end up with? But it's an option. Or in the unstable mortise, And I put the actual type here in the incorrect order, but some form of procedure for stability. And they're very unusual, but there would be benefit to, in isolated select cases, not isolated select cases, to have a fibular advancement, for example, create the stability of a mortise joint, or potentially to fuse a tibia-talar fusion with a normal foot to accept the fact that, well, let's keep the foot, but sacrifice an ankle joint itself, relying then on subtalar movement. I think that those are possibilities, and I don't think that they're going to be hard and fast rules, but to have a simplistic view that all of these are reconstructible would be missing the point. Okay. Anybody, any comments thus far? Nope. Then in terms of what is congenital, and remember that the term congenital is going to include everything that you're born with. Now we've got a patient, newborn, you've been called to the nursery. There's this weird looking foot that is dorsiflexed, and just out loud, I won't pick on anyone. Is there a visible dimple? Is not, because we've got a massive name tag, but I'm just telling you there's no dimple. The is there a bow? Yes, there's a bow. And remember, we named the direction of the bow as to where the apex of it goes. And so it's posterior and it's medial. Is the foot normal? It is, I'm telling you it is. It's got the normal amount of toes and it's got a normal ankle joint. It does have excessive laxity in a dorsiflex, despite the fact that there is bone underneath here. There's also a more than usual amount of dorsiflexion of the ankle joint itself. I grant you that. And so this is going to be our third deformity. This is a posteromedial bow. Associations, anybody? Packaging defects, what are they going to be? Okay, so this would be the calcaneus valgus foot, yeah. The other ones, when you talk about packaging problems, DDH is going to be there, yes. Your postural club feet are put into the same breath. I know it's the opposite deformity, but it's also a packaging defect. Anything else we consider the same light? I haven't got anything. The natural history, we spoke right at the beginning of what is the natural history of this thing going to be? The posteromedial bow. So what's going to happen? I should have got a whole series of x-rays. I'll show you guys. Dane, you were there. Were you there? You were there. Were you there? There was one came into the clinic 2-3 weeks ago. Anyway, basically we had an x-ray at birth. I didn't have a clinical picture. The x-ray often undertells the story a little bit in terms of what you see clinically, but the x-ray showed a bow, probably in total of about, let's say, 70-80 degrees, which rapidly starts realigning itself. So it starts growing straight. The foot becomes plantar usually, but by the time the child's walking, and sitting about 2-3 years, yes, there's still a valgus foot, there is, and still a tendency to dorsiflexion, correct, but a plantar foot nonetheless. What remains behind is going to be a leg length discrepancy, and now, in contrast to all of the other leg length discrepancy, is static or ongoing. No, it's going to be a static, so 2 to 3 centimeter leg length discrepancy. It's not going to increase over time. So you can kind of make the call fairly early on, for the next 5 years, of a 2 centimeter shoe race, and then make the call as to whether or not this particular child needs a largely cosmetic lengthening on that side. Remember that you don't want to be touching any sort of congenital deformity if you can help it, but they do lengthen, or contralateral growth modulation, or just leave it alone. Remember that a cosmetic deformity only starts occurring in adulthood after about 2 centimeters. Most leg length discrepancies under 2 centimeters are not cosmetically visible, and we've been through this whole debate. They don't pose a threat to low back pain, hips, or knees. And that's my final word on that topic. So largely, it's this actually is a 35-minute consult that just says it's going to be fine. All right, and your other children aren't going to have it because they're normally firstborns, and you generally don't get packaging defects on children's number 2 through 8. Static deformity. Okay, now you like the little hyperlink. Do you want to test it? So now we get to what we call a different kettle of fish entirely. Have we got an Afrikaans, anybody, idiom for kettle of fish? Anybody? Full van 'n ander kleur. Is it? Bad van 'n ander kleur. Is it? Okay, cool. There we go. Bad van 'n ander kleur. Anybody? Where's the bow going? Where's the apex? Is it anterior, posterior, medial, lateral? Anterolateral bow. Do we see ray deformities? No. Is it a relatively young patient? Yes, it is. It's sagging. It is. But there's only one kyphosis of the leg left, is there not? Congenital pseudarthrosis. There's that. I'm going to skip through some of it. It was originally a instructional course lecture. So there you got your diagnosis. Hopefully, at some point, I want to put in clinical features. It's not a. Now, don't get smart in your exam. I know it's not congenital, but that's what we call it. It's the pseudarthrosis actually occurs after birth. You don't get born with it. You do have the predisposition to it at birth. Yes, I'm right here. But you only fracture later. And it's not truly a pseudarthrosis, it's a hamartoma. You don't have a false joint. So it's neither congenital nor pseudarthrosis. I get it. Just try not to tell me that in your final exam. Try and just make me happy. All right. I don't mind being you pointing it out to me, but it's gonna just don't do it. Fine. Unless you're very, very confident of your gold medal. Okay. So it's actually a non-union of an existing fracture develops spontaneously. Remember that Muhammad had the nice little mantra about soft bones and that concept of you fix a fracture to prevent the ongoing deformity in soft bones. Remember that thing? And you straighten the soft bone to prevent the fracture. Remember that little thing? So this is, you don't. And yeah, I thought it was quite a nice simplistic thing. So, dope. Yeah, it was kind of, it made sense to me. So what happens in a congenital pseudarthrosis is that you get a process where you start getting more and more of an anterior medial bow, and eventually any bone even with physiological load is going to get to a point where it is unable to tolerate what we would call normal stresses of daily living. So if I fixed your tibia at 150 degrees and I dropped you down 2 stairs, you would break. It's just, that's how it is. At the same time, if you had enough of a deficiency in your growing bone, without fracturing, you would start bowing to the point where you're eventually going to fail, fracture. So these two things follow each other. And I get the synergy between the two processes, but we'll talk a little bit about jumping in and doing, let's call it prophylactic surgery in CPT. The actual pseudarthrosis develops apparently spontaneously, but it's on a background of a non-axially aligned tibia. That makes sense. there is a dysplastic bone segment, and the fracture itself usually occurs in the first 2 years of life. I've now seen 3 non-dysplastic, non-fractured CPTs in my career. The one was the child of a general surgical registrar. They moved back to Nigeria. And the other 2, I remember, they stick in your mind because they're unusual events. The 2 things that singled them out was A, the relatively undysplastic bone segment, so relatively non-dysplastic, and 2, the lack of angular deformity preceding a fracture. They maintained alignment and they didn't have a lot of disease. Right, but normally they're going to fracture. Etiology, no, here's the funny little hoop that you have to jump through. Of all CPTs, remember we're going to see CPT, yeah, congenital pseudoarthrosis. Of the CPT in front of you, 40% are going to have neurofibromatosis 1. So it's very likely that you're going to be dealing with an area. And I haven't got the stats for your short, sharp curve in spines. Anybody who's spines? Anybody? Throw it out there. But I would suggest that probably that malignant short, sharp curve in a patient under the age of 5 must have a similar incidence of CPT. What I'm trying to say to you is by the time you've got congenital pseudoarthrosis, the tibia, look for NF1. You're highly likely to find it. At the same time, for those people sitting in a genetic clinic, faced with all of those CPTs, or faced with all of those neurofibromatosis, only about, my figure is 7%, I don't know why. Only somewhere between 5 and 10% actually going to have NF1. Yep, makes sense? Good. The electron microscopy and histopathology, it's the base underlying pathology is a hematoma. Hematoma, by definition, I'm not going to go through, I am going to go through this again every year, twice a year. Every time we see a congenital pseudoarthrosis, because you're all going to remember, you're going to forget what a hematoma is. You start babbling away about other stuff. But by definition, a hematoma, disorganized mature cells that are usually found in that organ, yeah? Just in a disorganized fashion. Fine. And remember my analogy? It's like going to the registrar end-of-year function, the reg dinner. Yes, you start off in the evening. Everybody who's there is supposed to be there. But by 11 o'clock at night, those elements that are there are behaving in a fucking disorganized fashion. Will you remember now? Okay, you're all supposed to be there, but for fuck's sakes, it all starts getting a little bit weird. So you do have hyperplasia of fibroblasts that are supposed to be there. Some people maintain that the fibroblasts drive a disease, that you get perivascular cuffing and ischemia, that it strangulates them. There's sheets of dense fibrous tissue. Certainly when you operate on them, there is this thick, mucky, thick fibrous tissue that there's a fibromatosis analogous to fibromatosis elsewhere, that metaplasia of pluripotent myofibroblasts in the periosteum between the broken ends of the tibia. In other words, there's tissue there that's preventing it from breaking through and forming, and that there's a strangulation effect, not just around the vessels, but over the tibia, the strangles, and you have this compression osteolysis. I don't know. Whatever it is, there's a wodge of tissue that is thickened, relatively ischemic, looks like scar tissue. It is fibroblast and it needs to be removed. And it's one of the steps that is important in the management of it. Etiology, there's no evidence inside of a neurofibroma. It's a hematoma. It's not a neurofibroma. There is, in the work by Cho, there is altered biology of that periosteum. And I think it's because that it has been infiltrated, not with osteoprogenitor cells, but rather by, let's say it's metaplasia or infiltrative fibroblasts. They're just not conducive to bone healing in any way. And definitely Rosbrook from New York, and this is Svetlana Lizarov, Gabriel's daughter. their work is about the periosteum being the factor that drives the disease. And I think that for me, if there's one part of the surgical procedure that needs attention, that is to strip away this thick and fibrous tissue that is the periosteum. Apart from that, I'm not really that bothered. So here's my clinical photograph. Those golden flecks are relatively unusual for me to see. It's one of my patients, but if you shine a light from sideways, and I'm not going to expect you to do this in the exam, I might give you a picture of you get striking iris hematomas. So different shades within the eye. They look at times quite both striking and pretty. But it's going to be one of your criteria. We'll go into the other criteria shortly. The Kim is the sort of nonsense that you're going to have to remember. The cafe au lait spots, the particular style of them is smooth, Dane, or rough. Coast of Maine, coast of California. No, so this is the smooth one, the California one, the smooth borders. The one that has the jagged edges are going to be the ones that are involved with the neurocutaneous side of things like McCune Albrights. They often go to the midline, they're not discrete like this, and they definitely got this jagged appearance. And then Kim, you're going to add to that at any points. How many cafe au lait spots do you want? 6, yeah. Yeah, size age, 1.5 in adults, 1.5 in children. Yeah. Then for me, so I'm going to have 2 skin things. There's going to be the cafe au lait spots and the cutaneous neurofibrometer. Yeah. Those are my 2 skin things. And for the cutaneous neurofibrometer, I want 2. Don't just want 1. Or 1 plexiform. Is that have you got it classified as a nerve thing? I've got the skin is the cafe au lait and the cutaneous. I've got the deep plexiform neurofibroma. I've got 2 bony things. Is that the 2 skin? Okay, so now you've got 3. Fine. Axillary freckling, cafe au lait spots, cutaneous neurofibroma, deep plexiform neurofibroma. I only need 1. I've got the bony lesion, which to me is the CPT. But I think it is congenital pseudoarthrosis or flattening of what normally would be semitubular bones, like ribs. Yeah, I don't in my head have the congenital short sharp scoliosis as a diagnostic criteria. Any one bony lesion, so you're going to include then, fine, you got it in, I'll give it to you. The 2 eye things are going to be the iris hematomas and the Lish nodules, correct? And the 1 history thing is going to be first degree family history. Again, Old Crawford, they seem to see a lot in the States. And Alvin Crawford's actually a spinal surgeon, but has got a lot of experience. And he says that it's the commonest, it has the commonest incidence of an inherited musculoskeletal disease in the States. But I'm never quite sure what he means by that. Does he mean that there are a lot of people who are autosomal recessive waiting to have a kid? You know what I mean? Or is it that common? I don't seem to see as many as he's got masses of experience. Or was it? Where's Al Crawford from? I need to know. Anybody? Cincinnati. So the Cincinnati group. Maybe they were all referred to him. I'm not sure. Then the optic gliomas. Sorry, that is the other one. Okay, that's the other 2. I'm going to brush through this because Dane's going to embarrass us with them. how much more that he knows. I don't even know which the affected side is. So they just make us look good. So the one classification that I've got, even that's not particularly useful, is going to be the Crawford, Albin Crawford. Non-dysplastic and dysplastic. The non-dysplastic is a group that I talked about. It is relatively little involvement and the chance of never fracturing. Then the dysplastic, which is subclassified into sclerotic, cystic, and lytic. I don't find any of them particularly useful. To me, actually, it's more useful to know how big it is and to know how distal it is. And I explain why now. Boyd's got a slightly more scientific approach, if you want to go with it. It's going to be a tibial defect with bowing. There's going to be that hourglass constriction, almost that candy licks, the middle candy licked appearance. Normally your kid licks the stick candy. When you go to the Randy Sisha, I don't know what's it called, the Afrikaner Kunstfeest, but then you don't get candy things. Where are you going to get candy sticks in the Scofius, man? I don't know if they're going to sell this sort of thing there, though. Yeah? Articoffee, is it? Exactly. The stickies, you know what I mean. Okay. So imagine you lick that in the middle. That's what we're talking about. Then you're going to have a pseudoarthrosis through a cystic lesion, pseudoarthrosis and a sclerotic lesion, dysplastic fibula, not fibulae, and an intraosseous neurofibroma. I don't find any of that particularly helpful to me, but there it is. So we faced with a congenital pseudoarthrosis. And here are our goals in the specific management. But I want us to take all of ourselves just back one step. I think that one of the instructions in the management is to wait as reasonably long as possible. And the reason for that is the smaller the child, the less space, the less soft tissue, the more growth left, all of those reasons. Most of us would not jump in until our hand is forced, either by an angulation so severe that we just know it's going to fracture or fracture itself. And so the treatment up until this point is going to be bracing. There's another packet of chips there. Bracing. And the bracing is going to be to prevent fracture and hopefully keep the legs straight for as long as possible. And once we've jumped into treatment, then our goals are going to be this: elimination of that soft tissue hematoma. You need to get rid of it, because without getting rid of it, you haven't addressed the pathology, and whatever you do subsequent to that is doomed to failure. And then there's going to be a whole lot of, and remember that the compression distraction, both Paley and Lizarov, started with surgical excision, and then whatever was left to stimulate new bone formation was going to be the compression distraction or excision alone, which was Wieland and Perry-Schunecker. The stimulation of healing is going to be, once again, compression distraction, bone graft, vascularized bone graft. And for a while, there was a vogue for electrostimulation of basically everything orthopedic. It has now fallen away and, I don't know, gone into the realms of chronic pain and who knows what else. Where else has it gone? Probably rejuvenation cosmetics. Where's it bounced to now? Certainly, have any of you heard people getting electrocuted at low voltage in orthopedics for a long time? No? Fun, yes. Well, let's keep this now to just.
An acupuncture physiotherapy.
Do they do electrostimulation? Okay, fine.
I think it's called TENS, actually.
TENS, now TENS is bloody 30 years old, I'm telling you.
No, that's still
Yeah, so it's resurrected itself with as a distraction stimulation process, like deep heat, only with electrodes.
Yeah,
Fine,
exactly.
got it. Or don't say this out loud, or acupuncture, but without those little charts that show you the. Okay, fine, I'm moving on. You know, your meridians and the ley lines and all of that stuff. Gotcha. Don't give me that look, Mud.
Star signs as well.
Your treatment, I've said here treatment goal, but it's not really a goal, it's a principle. The treatment principle is going to be for post-operative immobilization. So circular X fixes, and Stefan Kalane, who is in Pretoria, is a big fan of this. He's very good. He's meticulous and it's successful in his hands, but for a lot of the rest of us, it might be an adjunct, but maybe not a mainstay of treatment. For a long time, and I think I'm still a fan of intramedullary rodding. Remember the little mantra about IM rodding? Load, sharing, not load bearing. It doesn't cause stress shielding. For me, the big advantage is once you've got union, you can leave it behind. And even in those thin, sort of tenuous, iffy unions, there's still something in the middle just to keep everything in place. I'm not a fan of the monolateral frame. The biomechanics, I don't think, lends itself to CPT, but they are described. And then principles, not goals, treatments prevent late refracture. Now, I've had one patient referred from a colleague of mine in Durban, came through as an accounting student at UCT at the age of 19 or 20 with a refracture. They happened late. And at that point, she was cut for. She wanted an amputation. So I think part of preventing a late refracture, and they're very troublesome. Remember, it's dysplastic bone, and it doesn't heal properly. So splint until maturity, skeletal maturity, absolutely. But think about intramedullary rodding. Think about something quite stiff. And I'm not sure that a small telescopic rod has the required amount of stiffness. They've got a lot of give in them. But perhaps those that are bigger, the 6 to 8 millimeter telescoping rods, perhaps, yeah. Maintain axial alignment. We talked about this before. If you skew, you're going to fracture, and if you fractured, you're going to get skewed. Just to paraphrase Mohammed. Right. These are the treatment modalities. Excision, Williams rodding, that was our mainstay for a long time, remains mine. Elizarov transport, I sort of dabbled in for a while, but it adds quite a significant component to the actual procedure. So basically, you get docking at one side, and you have distraction at another, or you have true transport. Vascularis fibula graft, it's got promise, yeah. Still excise the hematoma, yeah. Didn't compress directly down onto that, no. And I'm still of the opinion, and most people are, that the excision of that hematoma is very important. And then query this electrostimulation. But so I'm going to jump through this. This is an excision, so we work out. This is a fairly classic X-ray. You've got the bowing, you've got that dysplastic segment, you've got the fracture. You need to take away. You need to be cutting back to reasonably good bone. I'm not going to entertain the whole debate about MRI, because actually a large portion of that tibia is going to be dysplastic, not just the section you see. I'm not sure that it helps you. I think point of contact, reference, bleeding bone is probably better than anything else. I've made a point, and I'm just going to stop here and just say to you guys that if that pseudoarthrosis occurs right in the middle of the shaft, then you've got a good section of tibia distally to hold on to, intramedullary or whatever. But if it occurs very distally, your adjacent bone is wide, soft, is not dense, and is a poor intramedullary means of maintaining position when you're trying to get this to heal. And so I think that the distal fractures do worse. We haven't got enough numbers to prove it, but I do think so. One of the one of the options that we have used is in the very distal fragment to leave your Williams rod down into the talus, and it hurts because the breach of your ankle joint. But if you think to yourself that you're probably otherwise going to end up with severe varus, that might be an acceptable thing. And at times we've gone one step further, left the intramedullary rods in the calcaneus. Look, to be quite honest, we had McNichol from Edinburgh, who came across, and at that stage we were doing a congenital pseudarthrosis, and his comment and the whole thing after 4 or 5 hours of sweat in theatre was that he would amputate. Where would he amputate? Above, at, or below the segment. So just immediately above. Keep as much usual length. So basically go for as normal a below knee amputation as you can. Never obviously amputate below it. This is the excision of the hematoma. I'm going to jump through, jump back. Williams rodding. Williams rodding is just a variant of an intramedullary rod, but it's got let's call it a positive and a negative screw. It's got a they and them screw fixation. It allows one to place the rod and to be able to extract the positive screw. Bone graft. So decorticate the bone that you're going to be laying a bone onto, and our technique was what we did the other day in theatre, and that's to get your little your corticomedullary strips, and then to in between that have cancellous graft. There are some people who would add periosteum from the inner table of the pelvis. Happy with that. I never stopped to do it myself, but there you go. Just to remind you, this is the De Bastiani technique. To drill an osteotome, making lots of little holes, and then completing the corticotomy with an osteotome. And obviously, if your consultant has bloody sharpened the osteotomes himself, try and avoid the Williams rod cutting the bone, please. This is one of our cases. Bear in mind, this is a low fracture hand. So you can see distally just in X-ray number 1, 2, 3, there's the actual CPT. It's been excised, and the bottom rings are compressing, and then the top ring has a distractive process above. On the far right, you can just see the top piece now distracting away from the Williams rod, by the way, which is one of the problems that can happen. Not the end of the world, because it should be relatively innate and relatively normal bone. So that was the end of that. And so now, Scalp, have you got any questions for us?